Hi, everyone. I'm Michelle Sholzberg. I'm a hematologist at St. Michael's Hospital in Toronto, Ontario, and my focus in hematology is on coagulation. Today, I'm going to talk about blood and hemostatic therapies for the management of massive hemorrhage. This program has received no financial external support, but here are my disclosures as they pertain to advisory boards and speaking engagement, as well as unrestricted research funding. And these are the makers of some clotting factor concentrates. What I'm going to be presenting to you today comes from a wonderful team that I worked with, and we all put together the lovely infographics that I'll be referring to throughout. Today, I'm going to discuss the rationale behind a minimum 2-to-1 ratio of red cells to plasma in the Ontario Massive Hemorrhage Protocol, to identify component and product usage in the absence of a group and screen, discuss the rationale for rapid administration of tranexamic acid and reversal of anticoagulants, and also to discuss massive hemorrhage management amongst patients with inherited bleeding disorders. So let's start with objective 1. So the first objective pertains to the 34th recommendation in the published CMAJ report on the massive hemorrhage protocol for Ontario, that describes that the initial management of the rapidly bleeding patient that precludes the use of laboratory guided transfusion should begin with immediate red cell transfusion, and then transfusions at a red cell to plasma ratio of 2-to-1. And this is based on 2 randomized controlled trials that failed to confirm survival benefit of a red cell to plasma ratio of 1-to-1 when compared to 2-to-1, and also a large retrospective review looking at pre and post implementation of a 1-to-1 resuscitation strategy that again failed to show mortality benefit. Furthermore, a Canadian consensus conference on massive transfusion recommended a ratio of 2-to-1, then followed by transition to laboratory guided administration of blood components as soon as is possible. Apologies for the dog barking in the background. So this brings us to our next objective, to identify component and product usage in the absence of a group and screen. So in bleeding patients, the need of a red cell transfusion on cross-matched red cells should be transfused until cross-match compatible red cells become available. And this is based on retrospective data indicating that faster time to delivery of the first unit of red cells was associated with superior survival. In fact, with every minute delay to the first pack, there was a 5% increase in the odds of mortality. And why this is so important is that to provide cross-match compatible red cells, it requires a minimum of 70 to 90 minutes for the process of collection, handling, testing, and reporting. And this really isn't appropriate to wait for cross-match compatible red cells, given what I've told you above. And so in cases of severe traumatic injury where there can be communication with pre-hospital emergency services, it would be appropriate, in fact, to order red cells that are uncross-matched in the emergency, to bring them to the emergency department in advance of the patient's arrival. And certainly to switch to cross-match compatible red cells as soon as they become available. Now, if the blood group is unknown, RHD negative blood cells should be used only for female patients of childbearing potential that has been defined as under the age of 45 years. And 45 years was chosen as the threshold because over 99% of births occur among women under the age of 45. And so why are we suggesting that ORHD negative stocks be used only for this patient population is because the stocks are insufficient to allow for all patients of unknown blood group to be supported with group O RHD negative red cells until the blood group is released. And so we know that the risk of alloimmunization of an RHD negative patient after exposure to D positive red cells in the setting of major bleeding is 20%. But this immunization is really only relevant for females who wish to have future pregnancies. And so again, this is why these protocols should restrict the use of group O Rhd negative red cells for women under the age of 45, but efforts should be made to determine the age of women early, so as only to offer this to women under the age of 45, and it may not be particularly obvious as the massively injured young woman, her age might not be particularly apparent. So for conscious women, we try to determine their age early, and also with the use of her identification in her wallet. The risk of immunization for Rhd positive platelets is only at 1%, and so Rh immune globulin should be provided only to Rhd negative women under the age of 45 years in this case. Fibrinogen concentrate is now becoming standard care for the replacement of fibrinogen. And so 4 grams of fibrinogen concentrate is equivalent to about 10 units of cryoprecipitate. And it can be used as a reasonable alternative for fibrinogen replacement. And why is this? So cryoprecipitate takes about 30 to 45 minutes as it is provided as individual units that have to be thawed and reconstituted with saline and then pooled. It has to be transported up to that point prior to thawing, frozen at all times. When it remains frozen, it has a shelf life of approximately 1 year, but once it's thawed and pooled, it expires after 4 hours. And thus this might not be appropriate, particularly for small hospitals. And thus it is certainly reasonable to use fibrinogen concentrate in this setting, and also in fact in larger hospital settings. And of note, these fibrinogen concentrates are pathogen reduced. Additionally, similarly, particularly for smaller hospitals that do not have frozen plasma available, prothrombin complex concentrate, or PCCs, 2,000 units can be substituted for frozen plasma, but it's important to acknowledge that PCCs do not contain fibrinogen. Thus, fibrinogen replacement should also be given concurrently with PCC unless the fibrinogen level is known to be above 1.5. And so this is because there are similar challenges with frozen plasma, thus some smaller organizations may have some difficulty in providing this during an MHP. And really, though, this strategy of using PCC should be used as a bridge before transport at an institution where frozen plasma and definitive surgical management will be available. Of note, PCCs are in fact a common strategy that is used in European countries as well, along with fibrinogen concentrate, and they often use viscoelastic testing to guide their transfusion-based strategies, and their outcomes appear to be similar to those with plasma resuscitation. So to this end, our working group developed an infographic that describes the approach to what should be in each of the transfusion packs with massive hemorrhage. I'm going to focus on the large hospital, as I know my colleague, Dr. Pendergrass, has already reviewed the small hospital approach. And so pack 1, it's about red cells, provide them early. Pack 2, this is where we're going to start to introduce frozen plasma. Pack 3, this is where fibrinogen replacement is being considered. And then pack 4, we're going back to the frozen plasma. And the suggestion from our group is to alternate between packs 2 and 4 until the lab test values are available. Now, platelets should really be provided as needed and based on the platelet count result. Again, we also provided an infographic that suggests when to consider transferring the patient out. And I know that Dr. Pendergrass is reviewing this as well. So the third objective is to discuss the rationale for the rapid administration of tranexamic acid and the reversal of anticoagulant drugs. So tranexamic acid is a very important medication that was developed a few decades ago in Japan. And tranexamic acid is an antifibrinolytic in that it is a synthetic analog of the amino acid lysine, thus acts as a competitive inhibitor to fibrinolysis. The data in the setting of massive hemorrhage, really I'm going to focus on a few key trials here, comes predominantly from the CRASH-2 trial, which is a large international RCT that compared tranexamic acid versus placebo amongst adult patients who were severely injured. And here they provided 1 gram of tranexamic acid and then an additional infusion over 8 hours, again at 1 gram. The primary outcome was death within 4 weeks of injury. And importantly, Early tranexamic acid, i.e. early having been provided under 3 hours, reduced any cause of death in bleeding trauma patients. So it reduced all-cause mortality, really important. In addition, there was no increased risk of thromboembolic events. And so I really like to think of tranexamic acid as a clot stabilizer. It's not going to trigger a pathologic blood clot to develop, but certainly if one were present, it might worsen it. But importantly, this, along with many randomized controlled trials and meta-analyses, do not indicate an increased risk of thrombosis. So this really should not be of concern to the individuals involved in the management of a patient with massive hemorrhage. The woman trial is another critical trial that looked at women with postpartum hemorrhage and compared tranexamic acid to placebo. The primary outcome was composite of mortality and hysterectomy, and secondary outcome was death due to bleeding. Here, the loading dose of tranexamic acid was provided at 1 gram, and then a second dose was provided if bleeding continued after 30 minutes. Again, it was found that early tranexamic acid use reduced the risk of death, but here not all-cause mortality and hysterectomy, which was the primary outcome composite, but it did decrease the risk of death from bleeding. And again, there was no increased risk of thromboembolic events. Another trial that I will mention is the HALT-IT trial, which looked at adult patients with gastrointestinal bleeding, comparing high-dose tranexamic acid to placebo. Here, you'll notice that the dose is bigger than the dose that was provided in the other clinical trial. So a 1 gram loading dose and then 3 grams IV over 24 hours. So a little bit higher dose. And the primary outcome was death due to bleeding at 5 days. Interestingly here, there did not seem to be a decrease in mortality associated with gastrointestinal bleeding. There was an increased risk of seizure and seizure risk with the use of tranexamic acid, as it is known to interact with the GABA receptor, does seem to correlate with higher doses of tranexamic acid. And there also seemed to be an increased risk of venous thromboembolism amongst the patients who were treated with tranexamic acid, with a number needed to harm of 250. Why might this be? There were older patients included in this study and more comorbidities, in particular liver disease. And we know that patients with significant liver disease have diminished fibrinolysis. So perhaps this was one of the reasons why this signal for one of the very few clinical trials that have indicated an increased risk of VTE was found. And so tranexamic acid, therefore, is not recommended for an acute GI bleed, frankly. However, if a patient had a massive hemorrhage from a gastrointestinal bleed, I personally, as a hematologist with focus on hemostasis and coagulation, would not hesitate to provide at least 1 gram intravenously as a loading dose. So in summary, tranexamic acid should be provided as soon as possible, as soon as venous access or intraosseous access is achieved. And really, it should be provided within 3 hours of injury, earlier being better. And in fact, the survival benefit decreases by 10% for every 15-minute delay. And there seems to be no substantial benefit after 3 hours from injury or the onset of bleeding. The dosages and infusion rates certainly vary by study protocol, and therefore we have suggested in the recommendation document to use a protocol that makes the most sense locally. Certainly, anticoagulation should be reversed as soon as possible, and there are specific reversal agents that should be utilized. So for warfarin and the direct 10A inhibitors, it's prothrombin complex concentrate, not to forget vitamin K for patients with warfarin-related bleeding. For dabigatran, it's idarucizumab. And for heparins, whether it be unfractionated or low molecular weight heparin, this is where we're going to consider the use of protamine. And this is also included in our infographics. And then finally, I'm going to discuss the management of patients with inherited bleeding disorders when they present with massive hemorrhage. Here, what is important is that physicians should suspect that a bleeding patient might have a bleeding disorder if their bleeding is not in keeping with the severity of their injury and it is confirmed that they are not on an antithrombotic therapy. And also, certainly, if there's a personal or family history of bleeding, if that history is available at the time of resuscitation. So we really suggest looking for a medical alert bracelet, tag, or bleeding disorder card. And if a card is found, the mantra here is treat the patient first, then connect with a hematologist, ideally one with expertise amongst patients with bleeding disorders. And so there are hemophilia treatment centers across the country, and we have provided in our infographic the list of hemophilia treatment centers in the province of Ontario. So in summary, we've discussed the rationale behind the minimum 2-to-1 ratio of red cells to plasma. And this is because there doesn't appear to be a survival benefit to 1-to-1 resuscitation. In terms of identifying component and product uses in the absence of a group in screen, uncross-matched red cells should be provided up front because for the delay of red cell transfusion up front, there is a higher risk of mortality. But once you can provide cross-match compatible red cells, it should be done immediately. It's critical to follow protocolized packs and then to switch to lab-guided care as soon as possible. Now, with regards to the administration of tranexamic acid and reversal of anticoagulant drugs, tranexamic acid should be provided as early as possible and to specifically reverse anticoagulation as early as possible as well, because certainly it's going to contribute to the risk of ongoing bleeding and death. And then also amongst patients where an inherited bleeding disorder is suspected, look for a treatment card, treat the patient first, follow what's on the card, and then connect with a hemophilia treatment center ideally. I thank you all for your attention, and I'm happy to take any questions.